Welcome to the webinar of the EAPC Research Network Junior Forum. On behalf of this group, the Junior Forum, I would like to welcome you to this webinar. My name is Gina Curita, and I'm professor in pain and palliative care at the University of Copenhagen and Rigshospitalet in Denmark, and I'm chair of the EAPC Research Network. I have the special task of managing the Junior Forum with the steering committee composed by the Junior Forum members. Today we have here with us Arun Goshal and Babita Krisman that are part of this steering committee. We have a quite tight schedule today, but with some flexibility for the questions part of it. And I would like to invite all those that are not members of the Junior Forum to please to subscribe and become aware of all the activities that the Junior Forum has provided to its members. The Junior Forum is open to all people interested in palliative care research, independent of age and professional background, and it is for free. You can find more information about us in the EAPC website. I'm also going to put the link for you here on the chat box. But if we turn to the webinar today, we have Professor Daniel from the University of Aalborg with us, and I would like to invite Arun to introduce him to us. Thank you very much and enjoy it.
Thank you so much, Gianna, and welcome everyone. Today we have registrations from all across the world. I'll just show the numbers before I go on to introduce Daniel. So almost around 93 countries I got to know from Kathy, and then there are like 72% working in specialist palliative care amongst the people who are joining today, and 88% work in a care setting. So amazing, and welcome to the webinar again. With that, I'll go on to introduce Daniel, who has been very kind to join us today as the speaker. So Daniel Ciampi de Andrade is MD and PhD. He is the Associate Professor at the Center for Neuroplasticity and Pain, also known as CNAP in short, the Department of Health Science and Technology, the Faculty of Medicine at the University of Aalborg in Denmark. So Daniel has a background as a clinical neurologist and specialized in pain medicine. He has also a special interest in pain and neuromodulation. Daniel serves as section editor for the European Journal of Pain and Advisory Board of Pain Reports. So with that, we are all set to go. The stage is all yours, Daniel. Thank you.
So big pleasure to be here. Thank you so much for the invitation. It's amazing the amount of people you gathered. So guys, colleagues from all around, it's very, very nice to be able to be here. So thanks for the invitation. It's a big pleasure and honor. So the idea today is that we're gonna discuss the assessment of pain patients, of course, with a bias towards things or characteristics that are relevant for cancer-related pain. But palliative care and also the pain field are multidisciplinary by essence. And it's very interesting when you have these fields that are all, we can argue that all fields are multidisciplinary, but some are very multidisciplinary, like sports, sleep medicine, palliative care, and pain, for example. And it's very exciting because it's a situation where the fields are always having people with different backgrounds showing the way they see problems or they frame challenges that we see and trying to help patients. And that's a field that we are always learning from other colleagues who have a different background. So my idea today is to give a view of a neurologist, pain specialist, how is the approach we do to try to classify pain syndromes. The largest emphasis of this presentation, as we agreed before, is to focus on the assessment. There will be some discussion about treatment, but it's not really the emphasis here. We could talk about treatment one day, But I saw that there were several questions about treatment, so I'll be glad to answer them if we have time, because of course we treat patients too. So, but I'll start. Focus will be on assessment. It seems not relevant, but before we even talk about pain, we need to pain in cancer patients, in people with cancer. We need to remember that pain itself is very prevalent. So I will not go into details, but the most common disease in the world is dental cavities. But if you consider symptomatic diseases, the most common disease in the world, everywhere in the world, taking all diseases together, it's tension type headache, and then migraine, and then low back pain, and then neck pain. We have several types of pains as the most common diseases in the world. And if you look at how much a disease affects life of people, there is a metric called years of life with disability. So to have a very high impact in years of life with disability, you need to have a disease that is very prevalent and very incapacitating and long-lasting. And number one is low back pain. It's almost 3 times as impactful as major depression. Then in the top 10, this is among all diseases, we have then chronic neck pain, migraine, and musculoskeletal pains. So among the 10 most impactful diseases in the world, considering everything together, we have 4 being, including the number 1, being pain syndromes. And this is super important when we remember that we spend in Europe more money with pain management and treatment and complications than all the budget for cancer, considering screening, treatment, long-term disability related to cancer. I'm saying all these things before we even start, just to make us very aware that when you have a patient with chronic pain, if we remember that the prevalence of chronic pain is in the general population is close to 20%. This is a meta-analysis we did considering developing countries. You have to remember that 80% of the world population live in developing countries. In a way, not living in a developing country is the exception in this planet, because only 20% of people in this planet do not live in a developing country. So in developing country, it's around 20%. In developed countries, it's around 20%. So every 5 persons living in their normal life, so outside the hospital, will have chronic pain persisting most of the time for the last 3 months. So when we assess a patient with cancer and pain, we need to remember this, because those who have chronic pain and develop cancer-related pain will have a different presentation. They may have different sensitivity to drugs, treatments, non-pharmacological treatments, to previous thoughts and beliefs and priors related to treatment, to prognosis. And it can be really challenging if you assess patients with low back pain who has metastases in the lower column, in the lumbar column, and then they tell you that they have the same pain they always had for the last 30 years, it's just worse now. Is it related to the metastasis? Not related. So we're going to try to talk about a little bit of this, about these challenges. But it's just a provocative sentence. But chronic pain only exists in epidemiological studies, because in real life, people have a specific type of pain. It's like saying cancer. Well, you talk about cancer when you do epidemiology studies, but a person has a type of cancer with a name, last name, a specific type of cancer, and then you have prognosis, treatment based on this specific type of cancer. So chronic pain is the same thing. People have specific types of chronic pain. And then we have a challenge, because if you look at the recent ICD-11, so until 3-4 years ago, we had some big problems when classifying pain. For example, 7% of the general population have neuropathic pain. We're going to talk about neuropathic pain in a while, but 7% of the general population. And we had no ICD-11 code for neuropathic pain, for example. This changed recently with the new ICD-11, where we have chronic pain classified in 2 big families. One is primary chronic pains or secondary chronic pains. Primary chronic pains are pains that are the disease, just like migraine or, for example, non-specific low back pain, where the disease itself is the pain. Just like when we talk about dementia, Alzheimer's disease is a primary dementia. It's not caused by another disease. It is the disease itself. And secondary pain is when you have pain that is associated or related to another disease. So if you have no pain, you receive oxaliplatin, and then because you have colorectal cancer and you start having new pain that is neuropathic, for example, it's a secondary pain, secondary to something. For example, all neuropathic pain are secondary to a nerve lesion that has an etiology. So some pains are always secondary, such as neuropathic pain. The most common diseases that I mentioned are primary pains, like primary headaches, for example, or non-specific low back pain. Okay, this classification is really nice if you need to code your patients and have nice registries, or if reimbursement is based on the registry, it's super nice, but it doesn't really help a clinician because the clinician doesn't think about this way. A clinician sees patients who will talk to us, will give us symptoms, and we're going to have an anamnesis, history taken, and then we're going to examine people. We still do it. And when we examine people, we're going to have signs. So a clinician will use symptoms and signs to organize types of syndromes, which is certain signs and symptoms, syndromes, and then they will try to classify based on the syndrome the type of pain patients have, because then this will be related to the prognosis, to the treatment, if it's surgical, non-surgical, if it's neuromodulatory, if it's pharmacological, non-pharmacological. So even though the ICD-11 is super nice to code and classify pains, it's not super intuitive if you are a clinician, because this is not a guide, it's not a flow chart. It's just a classification tree. And that's a limitation. So what we usually do, we divide chronic pain into mechanisms. And then if you're interested, we can discuss, because you're going to see we don't really know in detail the mechanisms of the types of chronic pain in an individual, because the mechanisms are hidden. I don't have access to them. I don't have ways to look at the neurons directly. I only have access to signs and symptoms. So it's called mechanistic descriptors of chronic pain, but I could call it symptom groups or syndromic groups of chronic pain, but it's not called like this. It's called mechanistic descriptors. If you take acute pain, for example, where we have inflammation, mechanical stimulus, or thermal stimulus depolarizing neurons, and then we have the perception of acute pain. When we talk about chronic pain, we have three big families, three mechanistic descriptors of chronic pain. One is called nociceptive pain. Nociceptive pain happens when you have tissue lesion. So it starts with inflammation or tissue lesion that stimulates our somatosensory system. Somatosensory system, we can just call it sensory system. It's easier, and it's not wrong. So let's just call it sensory system. I have a lot of lesion. I have a sarcoma. I have a orthopedic problem that is chronic. I have osteoarthritis. And then this lesion is bombarding my sensory system all the time. And some people who are born or are born or are already, we don't know if it's trait or state, but some people who are more resistant to these nociceptive inputs, they will get better as soon as the nociceptive input is removed. So these are people who have chronic osteoarthritis, for example, or a chronic lesion like a sarcoma. And then after surgery, the generator of pain is removed, and then pain is gone, and people get better. So patients get a new knee, get a titanium joint, and then pain is gone because you removed the peripheral stimulus. But around 20-25% of human beings, they will not go this way. These people who are more vulnerable to pain, and there's a huge amount of work on ways to detect these people before they get sick, but we're not totally there yet. So about 25-30% of people, if they undergo continuous somatosensory, so sensory painful stimulus, their sensory system will adapt in a wrong way. There will be something we call maladaptive plasticity. There will be a series of changes that are hardwired. You're going to have new neurons, you're going to have new neuron connections, you're going to have genesis of new axons, you're going to have new genes being expressed, you're going to have new neurotransmitters being expressed, channels to neurotransmitters that we were not using. It's going to be started to be used. So hardware changes in the sensory system that will make it very easy for pain to be processed. In a way, it's a system that is learning how to process pain very fast, very effectively, but so effectively that the peripheral stimulus becomes less important. And we can even have some instances, extreme instances, where we remove the peripheral generator of pain and pain remains. Because now any input from the periphery, even if it's not from nociceptors, can be processed as pain. This is called nociceptive pain. So everything starts with lesion. There is learning, changes, sensitization that lead to a better system to process pain, huge sensitization, structural changes. It's not only inflammation, there are hardwired changes. The representation in the cortex of your painful limb is different. Of course, this is to some extent reversible, but you have hardwired changes that helps pain to continue even if you remove the peripheral generator of pain. So that's nociceptive pain. There's another group, which is also a mechanistic descriptor called neuropathic pain. So neuropathic pain is a pain in a person that has a lesion, a disease to the sensory system. Normally, if you have a lesion to the sensory system, it can be peripheral, central nervous system, for example, a stroke, for example, spinal cord injury due to a metastasis and a compression of the spinal cord. For example, polyneuropathy after chemo. For example, a patient who has cancer and had chemo but had no pain and then went to surgery, and after surgery they develop post-surgical pain that is neuropathic. These patients, they have a lesion or a disease to a nerve or a sensory peripheral element or central element. It can be spinal cord or the brain. And something more, they have a tendency to have neuropathic pain. When I say tendency, it's just to remember that if you take 100 people who had a lesion to a nerve, most of them, all of them, will have a deficit, a loss in sensation. But only about 25% will have loss of sensation plus neuropathic pain. So neuropathic pain is something that occurs in people who had a lesion, but not everyone who have a lesion will have neuropathic pain. We don't know 100% why neuropathic pain happens. It's not related to the intensity of the lesion. That's known. You may have a huge lesion with a lot of deficits in sensitivity, for example, and no neuropathic pain, just have deficits, but no neuropathic pain. And sometimes you have a very small lesion in a very small branch of a nerve, and you may have very intense neuropathic pain. So the answer is not obvious. It's not the amount of denervation, it's not the amount of deficits, it's not the size of the lesion. There's a lot of research with more information on what happens in the brain when you have neuropathic pain, but it's not obvious reasons. It's not, for example, the intensity of the lesion or intensity of the disease that counts. Neuropathic pain also is related to specific descriptors. So the words chosen by neuropathic pain patients are special. It's not random. So most patients with neuropathic pain, they will, if you ask them every day or every time you see them, where is the pain? Neuropathic pain is relatively stable spatially. It doesn't go around the body. It stays where there is deficit, and usually more or less in the same place. Some patients can draw perfectly the region of pain. Not always, but it's possible. Well, something you don't see with muscular pain, something you don't see in fibromyalgia, something you don't see in the other pain type that I'm going to talk in a while. Usually patients with neuropathic pain, they say that their pain is burning, electric shock-like tingling, like ants, like small pins and needles, like a cold that hurts, so painful cold. So these are the descriptors that usually patients use to describe neuropathic pain. We're going to see in more detail neuropathic pain. And then we have a group called nociplastic pain. And nociplastic pain, it's a type of pain where you don't have, it's defined by not being nociceptive and not being neuropathic. So you don't have a clear tissue lesion that started the process. You don't have a clear lesion to the sensory system that started the process, but you have pain. Most patients with primary pains that I showed previously, right before these slides, on the ICD-11, have nociplastic pain. Of course, these patients, let's give some examples. Migraine, tension type headache, fibromyalgia is a very good example. So fibromyalgia patients have pain all around the body. They have trouble with cognition, sleep, mood, but they have nothing different from people structurally, from people without pain. They don't have a disease in the muscle, even though they have muscle pain. But if you do a biopsy of the nerve, of the muscle, it's normal. So you don't have a tissue problem. You don't have inflammation, even though you have pain muscles. You don't have nerve lesions. If you find nerve lesions in these patients, it's just to the same extent of control people who don't even have fibromyalgia. And even if you find some deficit in innervation, it never correlates to their clinical picture, to the pain, for example. It's completely, or patients who have the most common disease, most impactful disease in the world, which is non-specific low back pain. Non-specific low back pain, which is 95% of people with low back pain, are people who have lower back pain, but they have no structural abnormalities that are different from people without pain. They may have some prolapses, they may have a little small hernia, but not to the extent that is any different from people without pain. So they don't have a full-blown compression of a nerve. They don't have a full-blown listhesis, sliding of a vertebra. They have just the normal things that everyone who is older than 3 years of age will have on the spinal cord, some neurodegeneration, some articular degeneration, which is normal with human beings living in an upright position, but not different from people without pain. So this is nociplastic pain. These patients, they have an abnormal activation of the nociceptive system without lesion, without clear lesion. It's like having an alarm of the house turning on without any thieves coming in. So when we look at a patient with chronic pain, it doesn't matter if it's pain-related, not pain-related, we try to see if they are more in the nociceptive pain, neuropathic pain, or nociplastic pain, because treatments are different, prognoses are different. You may ask me, well, how do you see nociplastic pain in cancer? Well, for example, first, patients can have nociplastic pain because they are alive in the general population, so 1 out of 5 will have, and they may get cancer. And some people get worse of their nociplastic pain when they have cancer. But if you give aromatase inhibitors to women with breast cancer, half of them at least will have new pain after using aromatase inhibitors, for example. And 2/3 will have a phenotype of fibromyalgia. You can actually nowadays call it fibromyalgia because fibromyalgia is a syndrome. So it can be related or unrelated to a comorbidity. So it is fibromyalgia from the phenomenological and syndromic point of view. And you can treat it. So neuropathic pain, there are several examples in the world of cancer and pain. And nociceptive pain, as usual, is the most common type related to tissue lesion. So what are the steps that we take? So we usually talk to patients. Imagine a patient with neuropathic pain. They will say that they have loss of sensation, they have deficit, and that they have pain. And the pain, if you talk to them, they will say that it's burning, tingling, like a painful cold, for example. And then you're going to see, and that's super important, that the pain is located in an area that is denervated. So the area of deficit matches the location of the pain. That's super important. Sometimes I see some colleagues who say, oh, there's a patient with a spinal cord injury who have pain. Oh, neuropathic pain. Not necessarily. You may have a compression to your spinal cord and your pain is due to spasticity. Or you may have compression of the thoracic spinal cord and you have shoulder pain, which has nothing directly to do with the spinal cord. So it doesn't mean that because you have a neurological disease, every pain is neuropathic pain. That is wrong. You may have a neurological disease with or without pain. And if you have pain, neuropathic pain is possible. If you have neuropathic descriptors, burning, tingling, and if the pain is located in the area where you have deficit, because you need to have lesion and deficit, loss of sensation, sometimes allodynia, we're going to see this, in the area where the pain is. You cannot have a deficit in your hand and say that you have neuropathic pain in the shoulder. There needs to be a spatial overlap of the neuropathic pain and the area of deficit. And then we use our clinical tools to assess these patients. So when we assess patients, and then we can have, of course, diagnostic paraclinic studies, like if we're talking about a spinal cord injury, a structural MRI, if we're talking about neuropathic pain due to polyneuropathy, a confirmatory study could be nerve conduction tests. But these extra tests, you don't need to wait for them to treat patients. We treat after we make the clinical assessment. We are allowed to treat people based on our clinical assessment, on a pain, neuropathic pain that we say that is probable, even before saying that it's definite, if you want to use a grading system. And what we do, we usually use pins. There are several ways to use painful mechanical stimulation. If you have a tuning fork, more neurologists who like tuning forks. But if you have any metal rod, so metals in room temperature, if you're not in a super hot place, it's going to be around 25 degrees. So it's good to assess thermal perception. It's very sensitive. You can examine the painful area, ask the person, well, the normal area first, ask people if they feel properly the cold or on the cheek, and then you examine the painful area, and most often they will say that they have loss of sensation, or the same thing to pinprick. If you have loss of any sensation, it counts. You don't need to have deficit for all sensations. You can also assess non-nociceptive pathways, like mechanoreception, reception, just touch, with a brush, with your finger, with a cotton swab, with a piece of paper. So it can be relatively simple. So the basis is to uncover the body area that we're going to examine. We need to see what we're doing. Then we present whatever we are going to use to simulate. So if I'm testing thermal, I'm going to use the rod. I examine the normal area and I ask the patient, how is he feeling the abnormal area? There's no golden rule, but in general, if the patient is collaborative and paying attention, you can even do fancy stuff. Some patients, you can say, well, from 0 to 10, to which extent you feel this cold? How cold is this? So 10 is super cold and 0 is warm. And patients learn very fast. They can say, oh, 3, 4. And what about now? Well, doctor, now 0, 1. So differences that are significant to the person, usually we take into account. A golden number would be 20, 30% difference. Micro differences we usually don't pay attention to, because if the patient is too anxious, he may see micro differences, and that's usually wrong. But if you have clear, systematic differences, you can trust. You can assess normal touch. You can assess pinprick, which assesses pain fibers, nociceptors, which are related to unmyelinated fibers or thin myelinated fibers. And in the end, we're going to have some Greek names. We're going to have something that is called, for example, mechanical hypoalgesia. So mechanical hypoalgesia, it doesn't mean if you forget this, it doesn't matter. You can just write that there is a diminished sensation to pinprick, for example. It doesn't matter the name. But if you want to get fancy, you can say mechanical hypoalgesia. So you did something that is algesia, that is painful, that is hypo, that is low. So in the painful area, there is loss of sensation to pinprick, for example, because it's mechanical, for example. Then using these concepts, we're going to see some common situations in general practice, but also in the pain world, in the cancer world, which is one is polyneuropathy. So every time something's called pathy in the end, it means deficit. All the pathies, polyneuropathy, neuropathy, multiple mononeuropathy, these pathies means decrease, deficit. And deficit can be sensory, it can be motor, it can be both, or it can be in reflexes. It can also be in autonomic features, but autonomic features you need to be more trained, but if it's obvious, it counts too. So it's sensory, motor, autonomic, or reflexes. It can be just one. It's already pathy. So polyneuropathy, poly meaning all, many, it's a disease that affects all the nerves of the body. So by definition, polyneuropathy is a peripheral problem of peripheral nerves that affects all the nerves. Well, of course, if you're talking about a sensory polyneuropathy, all the sensory nerves. If you're talking about motor, it's a motor nerves. If you're talking about mixed sensory motor, it's both. In the cancer world, by far, the most common type is sensory polyneuropathy. Polyneuropathies are, by definition, bilateral and symmetric. And the large majority will affect larger fibers earlier than small fibers, than short fibers. It means that if you have a polyneuropathy, this is not there are some exceptions because polyneuropathy doesn't mean distal worse. It means bilateral and symmetric. You have some polyneuropathies which are proximal, so shorter nerves get worse faster. But 98% of times, polyneuropathies will be worst distally. So we are going to have the famous stocking and gloving pattern, where you have deficits that occur like a stock bilaterally on the legs and feet. If it increases, they will reach the hands, and also around the umbilical cord. Because you have to remember, the innervation of the umbilical cord comes from the back. So if you have a polyneuropathy that are affecting this length of nerves, you're going to start to lose a halo of sensation around the umbilical cord. And if you don't know this, this can be mistaken by a sensory level if you think that the person may be having a compression of the spinal cord. But it's common to have a small island of hypoalgesia or hypoesthesia around the umbilical cord. So peripheral, quite often distally distributed and symmetric, affecting reflexes, sensation, muscles, or all of them, or just one of them, and autonomic, having autonomic changes. If you ask for a nerve conduction test, these patients will have alterations in nerve conduction tests. There's only a small detail. Nerve conduction tests assess largely myelinated fibers, which are the fibers important for reflexes integration and for touch. If you have a nerve, if you have a disease that affects preferentially pain fibers, myelinated, thinly myelinated, A delta, or non-myelinated, unmyelinated fibers, which are called C fibers, if you do a nerve conduction test, you may not see these changes because nerve conduction tests, they only see large myelinated fibers. So sometimes we need to use some fancy exams called skin biopsy to look for innervation of the epidermis, laser evoked potentials to really determine that someone has a polyneuropathy if the polyneuropathy is only affecting small fibers, which are the temperature and pain fibers. So sometimes, for example, patients receive oxaliplatin, for example, they quite often have large fibers and small fibers affected. So if you do a nerve conduction test, you will see some changes. But for example, if they have, some patients develop a more small fiber pattern where the large fibers are normal. So nerve conduction tests may be normal. Okay? Some Vinca alkaloids can also cause neuropathy, but in general, you take large fibers a lot. So you can also detect using nerve conduction tests. So keywords, symmetric. Deficits have nothing to do with dermatomes because it's all the nerves that are being affected. It's not the root. They are not related to a nerve trunk. They have nothing to do with myotomes. They occur distally, preferentially, stocking and gloving, and maybe sometimes a tie around the umbilical cord. And you can use your eyes to help you. Usually these patients have dry skin on the feet, sometimes a little bit of foot drop, sometimes dystrophic nails. Usually they don't have a lot of hair in the feet. They have difficulty in feigning the toes. That's one of the first things that happen if motor neurons are affected. They may have autonomic features. They may have orthostatic hypotension, presyncope, and they may have something called orthostatic intolerance. If large fibers are affected, you may have the famous Romberg sign, where patients are standing up. When they close the eyes, as soon as they close the eyes, they lose balance. Because these patients, they are using vision to compensate for the loss of sensation. If you close the eyes, you only have your vestibular system helping you because you don't have the inputs from the sensory system. You close your eyes, you lose two inputs to the system, and now you rely only on your vestibular system, and you have a very sudden, fast occurring, as soon as you close your eyes, instability with no preferential side. That's a very easy test to do that you can do. Of course, you have to protect the patient. Some patient may fall, but it's very easy to do the test. There's a completely different thing that is radicular pain. So radicular pain, you see, there is no pathy in the name. So you don't need to have deficit. Radicular pain, usually, you may have radicular pain without the disease. But if you have only radicular pain, it's simply a pain that occurs because normally our roots, when we walk or when we stretch the arms, we stretch the roots, but we don't have any pain. When you walk, you don't have any pain. But if you have a root that is inflamed because of cancer compression, because of autoimmune problem, because of chemo, when you stretch the root just by walking, you may have something called an ectopic discharge. An ectopic discharge is a weird neuronal discharge that is created in the middle of the nerve, not really because you have a problem in the periphery, but just in the middle of the nerve that reaches the spinal cord. And the spinal cord receives that impulse, that abnormal impulse, and that impulse comes from the root. So you feel the pain projected to the area of the root. So if it's L4, it's going to be projected to the area of L4. So radicular pain occurs because you have compression or extension of a root and inflammation. Normally, if you have compression or extension without inflammation, we don't have any pain. But now you have these ectopic discharges with a very abrupt pain. But there's no pathy. So radicular pain alone, you don't have deficits. You just have the pain. It's a lancinating pain along the limb in the projection of a nerve. And that's what it is. And if you do the famous Lazeg sign, which is basically raising the straight leg of a patient, if you raise the leg that is extended, there will be pain because you're stretching the roots. But if you do the same thing, if you flex the hip with the leg bent, you're not stretching the roots anymore. And then there is no pain. That's the Lazeg sign. Oh, by the way, Lazeg didn't really write it. He asked a student to write, and it was his student who wrote the thesis and described the sign. He was just a professor being a supervisor and not really writing the thesis. So it was his student who published the thesis. The last example that I would like to give you is radiculopathy. So now there is pathy. So radiculopathy is a disease of a nerve root. And because we have disease, it can be a compression, it can be tumor in the peri-aortic region, compressing roots, L2, L3, for example, L4. It can be a metastasis. It can be just a cancer patient with herniated disc. So disease of the root, and then you will have deficit, can be sensory, can be motor, it can be reflex, or it can be autonomic, or all of them, or any combination. And now you have deficit. So you don't have ectopic things happening. You have blockage. You have conduction block. You cannot really have information being conducted by the nerve, by the root. So you have deficit. So if you say radiculopathy, you're talking about deficit. Of course, you may have pain. So you may have radiculopathy with pain or without pain. And you may have radicular pain with radiculopathy or without. It seems trivial, but the treatment, prognosis, rehabilitation is completely different. A radicular pain due to an inflammation of a root may very easily respond to steroids or local injection of steroids, for example. And the prognosis is relatively better than a radiculopathy because of a compression that is there for a while, leading to deficit, and not really responding to steroids or anti-inflammatories. They will rather, if there is neuropathic pain related to the radiculopathy, they would rather respond to other drugs. Just this is the next slide, shouldn't be here. It's just about the dermatomes. Bear with me. Sorry, shouldn't be there. Yep. And then the most important thing here, we learn that referred pain we learn referred pain when we learn, for example, heart infarct. So you have an acute myocardial infarction, and we have referred pain to the neck or to the jaw or to the arm or shoulder, and we should pay attention because this is referred pain. And this is true. But what people don't tell us in general is that referred pain is not specific to the heart or to viscera, not specific to the pancreas with pancreatic cancer. Referred pain occurs all the time in all tissues in our body except the skin and mucosa. So the innervation of all deep tissues, so forget the skin, forget mucosa, or muscles, or fascia, or tendons, or joints, are mainly innervated by thin fibers that have a very low discrimination capacity. We usually don't know where is our deltoid. Of course, if you have a trauma that hits the skin, we know. But if I inject a slightly painful substance in your deltoid, you will not have pain in the deltoid, you will have pain in your whole arm. So referred pain is pain perceived away from the lesion site. And it's super common in all types of musculoskeletal pain diseases. There are atlases of patterns of referred pain. And this is why you're going to see patients with knee pain, where the oncologist made a lot of MRIs or exams of the knee, but then you find a metastasis in the hip, and you have referred pain to the knee, because it's a pattern of referred pain. This is why you see patients with eye pain, and they have a normal ophthalmological assessment, but you find a metastasis in C2. And neck referred pain is called cervicogenic headache, is a classic type of headache that is caused by referred pain from the neck. It doesn't need to be a metastasis, it can be just compression of a muscle. It can be anything, it can be any structure. It's usually not very well localized. The site of pain changes from one day to the other, and it's very rare that patients will use neuropathic descriptors. Usually they say that it's a painful pain or aching pain or a dull pain. It's very rare that they say that it's electric shock-like pain when you're talking about referred pain. And it's usually sometimes even hard to localize. So imagine basically imagine that we have L4. When we talk about the dermatome, it's relatively easy. We're talking about the innervation of the skin. So L4 is very easy. You have roots coming from the skin of L4, going to the L4 segment in the spinal cord. But we have a lot of deep tissues who are innervated by pain fibers conducting pain stimulus to L4, but they are not related to the skin of L4 innervation. For example, parts of our psoas muscle, hip bone, tensor fascia latea, quadriceps, gracilis, gluteus minimus, gluteus medius, all these structures are partially innervated by pain fibers, nociceptors, that will go to L4 also. So you may have a lesion in the psoas, like a hematoma, or metastasis, lymph nodes in the psoas, or a fracture or metastasis in the hip bone, and that information will be integrated in L4. And the pain will be felt outside the L4 dermatome area. For example, L4 referred pain has this pattern, which is not exactly as the skin dermatome of L4. This is extremely common and maybe not so well studied, but super clinically relevant. Understanding that structures that are deeply located, which are not the skin basically, they will quite often present as referred pain. And referred pain is usually distal to the site of injury, with the exception of the neck, because in the neck, we have referred pain to the head. But from the neck down, it's usually distal. The general rule is that it's distal. And it's not neuropathic pain. It's just musculoskeletal pain that can be treated. We have a lot of patterns of visceral referred pain patterns, but they don't include the muscles. So it's important that you take a look at the muscles. And the last slides, we will not really talk about treatments, but we have to remember that we have systemic drugs. We also have local drugs. There's a lot of drugs we can use locally, but it depends on the type of pain, depends on the type of patient. The treatment is multidisciplinary, and the treatment can range from drugs to neuromodulation that you guys already are very excited about it, sleep treatment, psychotherapy, even hypnosis, depending on the patient, depending on the type of pain. Just remember, if you do evidence-based treatment for pain in general, most interventions that we do, every time we do anything that is not the OMS letter, that we do any association of drugs, we will have no evidence. So lack of evidence doesn't mean that something cannot be done or should not be done. We have much more lack of evidence than evidence. Of course, this is different from negative evidence. For example, we know, for example, that there's a lot of things that don't help patients with chronic pain. For example, we had a huge amount of cannabinoid studies showing negative results recently. We know that some types of anticonvulsants don't help patients with neuropathic pain. We know that serotonin inhibitor uptake blockers are not super effective in neuropathic pain. So these are negative evidence, which is good. But most of the times, we have insufficient evidence. And then we need to use our brains and discuss with patients, talk about preferences, cost effectiveness, discuss with the group, and try to find the best treatment. In a nutshell, in general, patients with nociceptive pain, up to 15 to 20% will remain refractory despite the usual treatment. And the treatment with more evidence is physiotherapy, rehabilitation, physical medicine, of course, anti-inflammatories, OMS letter, opioids, and you can use adjuvants like tricyclics or dual drugs that are serotonin and noradrenaline, selective noradrenaline or serotonin reuptake inhibitors like venlafaxine and duloxetine. For example, one of the few drugs that have evidence for treating neuropathic pain related to oxaliplatin. Neuropathic pain, we have some treatments. We use a lot of tricyclics. We also use venlafaxine and duloxetine. There is evidence for botulinum toxin subcutaneous, topic lidocaine, high concentration capsaicin if it's a peripheral and localized neuropathic pain, but also psychotherapy, TENS. And now, in the new guidelines, we're going to have transcranial magnetic stimulation and as official recommended treatment for neuropathic pain. The guidelines probably coming this year. And nociplastic pain, we use much less drugs if we can. We try to use much more rehabilitation strategies. If we use drugs, we might use low intensity opioids or whatever name we want to give. Weak opioids, not super nice to call them weak opioids, but basically tramadol, NSAIDs for a few days or a few weeks for an acute exacerbation. But if we need to use drugs, maybe tricyclics, maybe some other venlafaxine, duloxetine, and put a huge emphasis. I'm excluding primary headaches because primary headaches are different. But for fibromyalgia, non-specific low back pain, the emphasis will be on rehabilitation programs that are extremely important. Thank you so much for your attention. We're going to have some time for discussion, and I'm going to try to address the questions you guys sent. When I'm presenting, I cannot see the chat, so I'm going to check the chat now. I received some questions.
Daniel, Babita can select the questions and make to you.
Sure, but I copy and paste also. Okay. Okay, super nice. What's the difference between radiating pain and referred pain, especially in cancer? Yeah, so it doesn't matter if it's in cancer. The mechanism is the same. So radiating pain, the word radiating pain, we don't try not to use it because it's not super precise, but we tend to use radiating pain when talking about a lesion to a nerve. So if you have, it would be the same as I just explained the radicular pain. So radicular pain would be radiating. The word radiating in neurology doesn't mean a lot. It can be anything. So I would consider as a general word, radiating. So going towards something. But referred pain is more specific. Referred pain is a process where you have a deep tissue that has a lesion, and the lesion is felt outside the area where the lesion is, which is super common. Bone pain. Okay. Bone pain is a world. So first, we need to see why there is bone pain. Is it a compression because of osteoporosis, because the patient has risk factors and had osteoporosis? Is it necrosis, a septic necrosis of the femur? So first we need to look at the cause and see if there's a specific treatment for the cause. If it's a single metastasis, it would be interesting to see if it's not possible to remove the metastasis. If it's a collapse because of osteoporosis, maybe use vertebroplasty or treat the lesion. So bone pain, first try to see the cause of the bone pain. If you need to handle bone pain, we have all the classic procedures. We can use calcitonin, we can use bisphosphonates, and we can use general drugs that we would use for nociceptive pain, So more emphasis on non-inflammatory drugs, analgesics. In some countries, you have, for example, metamizole, which is dipyrone. In South America, for example, it's an amazing drug that is mainly unknown in many places in Europe and the US, which is amazing for this type of drugs, or this type of pains, and also opioids. Phantom pain. So phantom pain is treated like a neuropathic pain. So you would treat phantom pain like a peripheral neuropathic pain. So you can use tricyclics, you can use venlafaxine, duloxetine. Because the generation of the pain is in the periphery, you can even try to use lidocaine gel. Of course, you can try opioids, but you can even try, and there's only 1 or 2 studies, but you can even try subcutaneous botulinum toxin around the lesion. If it's the best thing for phantom pain is to very fast rehabilitate the patient and try to put a prosthesis. Just by using a prosthesis very fast and using the limb again, a lot of people get better. So if you have a rehabilitation team that will think about ways to, if possible, to use a prosthesis, if possible, for example, if it's in the leg, and use the limb and treat with drugs you would use for neuropathic pain, most patients will get better. Most patients. You just have to pay attention because Phantom pain is a type of pain that can occur in people with heart have amputation. But it's very common that the pain is not phantom limb pain. So phantom limb pain is a pain that occurs in the phantom limb that is not there. But many patients have pain in the stump. So it's a stump pain that then it's completely different. It can be nociplastic, it can be nociceptive, it can be inflammatory, you may have neuroma. So it's important to start to assess if it's a pain, phantom pain phenomena, and the pain is in the phantom pain, like and it has descriptors of neuropathic pain. But sometimes it's just stump pain. And stump pain, you need first to look with an orthopedic approach, first of all.
Thank you, Daniel, for a very informative session. We have some more questions which were submitted at registration. Also, we have some questions from the steering committee members. I'll just spell them to you one by one.
Yeah, but I can see
we have some questions from the steering committee members. In your opinion, what are the areas or themes in pain research that are understudied? Means this is basically a researchers forum. So
there are so many, because almost really, if you look into detail, any specific thing is understudied. For example, look at all the things I mentioned about aromatase inhibitors. It's a huge problem. We don't have a lot of studies looking into this. Of course, there are studies showing that acupuncture can help and some, but really in a comprehensive way, we don't. There was a lot of emphasis on prophylaxis of oxaliplatin-induced neuropathic pain. From my old days I worked for 10 years in the Cancer Institute as a neurologist. So we would use calcium and magnesium. We did a big study using pregabalin. Nothing really works. But we don't have that many studies looking at treatments. For example, I think that if we try to translate what we know from pain outside the cancer world to cancer patients, it would be super interesting. For example, we don't have a lot of studies using spinal cord stimulation for chemo-induced refractory neuropathic pain. And we did a few times in patients off-label. It helps as well as in patients with peripheral polyneuropathy, for example. But it doesn't need to be that fancy spinal cord stimulation, super complicated, super expensive, maybe not available. It could be more easier things. For example, how many times we saw studies looking at neuropathic postoperative pain treated by subcutaneous botulinum toxin. You use one injection every 3 months. And the odds, the number needed to treat is very low. It's one of the lowest in the treatment of neuropathic pain. That's just to cite an example. Neuromodulation. So TMS now is in guidelines for neuropathic pain. How many trials we did looking at TMS for neuropathic pain in cancer patients? Very few. That's my take. My overall take would be, let's try to translate what we learned from non-cancer pain patients into cancer pain patients, because of course cancer patients have a lot of peculiarities, but I would say that most of the mechanisms are pretty much the same.
This forum includes almost equal number of non-physicians also. So the suggestions might be, means your suggestions, if it covers a broad range of research topic rather than physician-oriented topics, it will be very useful. And the next question we have here is, can you provide 3 tips when identifying a research question and writing a study protocol in the field of pain research?
Very nice. So my advice would be, first, if you're doing pain research, there are some assessment tools that we use a lot. The way to assess pain, the primary outcomes, there are some recommendations on what we should assess. There are, for example, pain intensity, how to measure pain intensity, and how can we assess sleep in pain patients? How can we assess, of course, quality of life? You guys are already assessing the cancer world. But first thing, I would try to use tools that were used before and are known to be really good to assess pain. It's kind of obvious. The second thing would be to look into, of course, an original topic. But then I have a joke. I tell students that they should use the 3 steps rules. What is that? If you look at the literature today and say, wow, there's something super amazing, I need to study this because it's a knowledge gap that nobody addressed, and I'm the one, I just noticed, I'm going to make a research. The time you write a project, the time you get the money, the time you collect data and you analyze data and you finish, if you are super fast, it's going to be at least 2 years, average 4 to 5 years. And then there's a lot of people reading the same papers and having the same idea with you. And sometimes after 3 years, you'll see a publication on exactly the same thing, which is fine. Nowadays, nobody will die because somebody studied something just like you. But if you apply this 3 steps rule, it's really good because the rule is like this. Try to guess what are the results of your study and try to add the next step, if possible, in your study. For example, if you're comparing medication A and B, and you imagine that it's going to work, can you assess, maybe add a profile response, a responder profile assessment? You could add the next step. Like the next step of my research would be, well, it works, but who are really the responders? Because you look at average, maybe there's a profile of responders. Then in the future, I could maybe target my treatment to these guys having these profiles. So it would be super nice if you have a trial where you have enough statistical power to scrutinize or explore the profile of the responder. That's just an example. So you're kind of giving the next step already, and that's the 3-step thing. Try to give 3 steps ahead in your research, if possible. So it would be to think about the next step, or maybe the next 2 steps, or maybe the next 3 steps, and if reasonable and possible, try to add them to your assessment. Because then you always have something new, and you, by definition, you will be very advanced. That's my tip.
Thank you. The next question is, what are the common pain syndromes you have treated often?
That I treated, maybe it's biased. I would say, well, all of them. I would say I could say every type of pain related to cancer I could imagine. But I would maybe remember the most refractory and the most difficult patients to treat, in my opinion, are patients who have chronic pain before cancer, and then they have cancer, and then they have new pains on the top of what they had. So it's so important, this topic, and it's underassessed in research. We had an outpatient clinic just to see patients with previous migraine. So it's not cancer, it's just migraine. But when they develop cancer, they lose weight, they gain weight, they don't sleep, they sleep too much, they have side effects. It becomes super hard to treat the pain that they had before. So sometimes you have patients with chronic low back pain who developed metastases in the lower back. And then it's super hard to treat because it's people who have a lot of bad experiences with treatment. They don't respond the same way to medication. So my big challenge was to treat patients who had chronic pain and develop new pain after cancer. And then you would have to have these two perceptions. That's challenging. And we don't have a lot of data research-wise on this. And it's so common because having chronic pain doesn't decrease your chance of having cancer. So at least 5% of cancer, 20% of cancer patients will have previous chronic pain by definition, just because they come from the general population.
Thank you. The next question, do you advise invasive methods of brain treatment in palliative care patients?
I do, but I am biased. I worked in a center where functional neurosurgery was very strong. So I had the chance to have patients who had, for example, pancreatic cancer with pancreatic visceral pain. There was alcoholization of the celiac plexus. We did some neuromodulation in these patients with chronic pain. We had, for example, intrathecal morphine use with pumps, with infusion pumps. Even some surgeries that are not really done anymore, like cordotomy, we had the chance to offer to some patients. So I'm biased. I had a very nice experience as a neurologist, so I don't see blood. I don't use knives. I just use my hammer. So as a neurologist, I felt very fortunate to be in an environment where surgical procedures for pain were possible.
Yeah, I agree with you totally, but it's also patient preference, I guess, whether
Completely.
they want to undergo a invasive procedure. But
course.
if it really helps, they'll be really happy that they went for that procedure.
Of course.
Um,
And
and
also money, this
yes.
doesn't fall from the sky. So you need to see how this is, because if you spend a lot of resources to a surgery that's, you have some doubts, there will be a lot of patients who will not receive the basic treatment. So you need also to look at who's paying the bill. So there's a financial side to it.
Yeah. And we have some questions submitted at registration. What is the difference between relationship between total pain and suffering?
That's a nice question. I would say that the main difference is who wrote the book. So these are concepts from different fields. Total pain is a concept from centers, palliative care world, to a knowledge that patients with chronic cancer-related pain, which is very intensive, they will not only have nociception, they will have changes related to suffering, to mood, to behavior, and everything. Suffering and pain, there's a lot of very nice studies. So out of the cancer perspective, there's a lot of studies showing that you can dissect suffering from pain, and that suffering would be a different construct occurring in patients with pain, chronic pain. So maybe for most patients with total pain, suffering will be there anyway. I don't know if it's possible to have total pain without suffering. In the non-cancer world, we don't use a lot the concept of total pain, because we kind of consider that chronic pain is total by definition. It is affecting mood and behavior by definition to different degrees in all patients. But I understand the concept.
Yes, thank you. The next question is, can you imagine palliative care without opioids?
I can. You need a lot of resources. Of course, some patients benefit from opioids, there's no doubt. I'm not sure why we need to remove opioids from palliative care. I have a personal opinion. Most of the confusions and problems we have with opioids and have nothing to do with cancer patients having pain. But we used to do a lot of rehabilitation in patients who were taking opioids and could be weaned off opioids because they got better. But then you would need a very strong multidisciplinary team offering a lot of interventions that are non-pharmacological, and that's not super obvious. You need a big structure of a rehabilitation team with physiotherapists, a type of doctor that has different names in different countries. It's called rehabilitation doctor, or physical therapy and rehabilitation, or physiatrist, depends if you're in the US, in Europe. So it would be multidisciplinary teams with this type of approach. And then probably these patients will be receiving less opioids.
Yes, thank you. And the next question is, can we use the FLAC or phase scale to assess the pain of those adult or geriatric patients who are semi-conscious or unconscious?
No, you can't. You have to use specific tools. For example, there's a long list of pain that are made for assessment of behavior. So there's a general rule. If you're assessing pain of someone, it's a better way is to talk to the person and ask the person. If the person cannot talk because it's a fetus, because it's a newborn, because it's a kid who's too young, because it's an elder who has aphasia, cannot talk, or if it's an older with dementia, the second best thing is to talk to caregivers. Caregivers, like a mother of a child or someone who's close to the patient, give very accurate description of what's going on. It helps a lot. And of course, observation. And these scales that I mentioned, they look at behavior. So behaviors that we interpret as being related to pain. But the VA scale, it's impossible.
Thank you. We have a few more questions. I think this is all covered in the presentation. They are how to manage psychosomatic pain as primary contributor in cancer, nervous dysregulation and maladaptive neuroplasticity in chronic pain conditions, and what is the role of interventional pain management in palliative care. I think these are all covered in the presentation. In case if you want to add anything to these questions.
Well, somatoform disease and pain, it's super complicated. And we always, if somebody says they have pain, they have pain. Then it's a matter of what is the mechanism. And somatoform problems can be a reason to pain. But in the context of cancer, I would suggest that it's never the first, second, or third option. I would always try to look for other reasons, because you don't need to have lesion to have pain. You just need to be born and alive. And then 20% of people will have, and most common types of pain are primary pains. So you don't have a lesion to the system. You just have pain. So I would try to frame and characterize the pain of the patient in a way before trying to call it somatoform in the cancer world, because you can make big mistakes, because the treatment is very different. The second one, when we talk about neuroplasticity, maladaptive plasticity, it's super important, but these are mechanisms that are present in all types of pains. So they are important to understand pain, but it's not something like you say, oh, I'm going to use this drug A because there is maladaptive plasticity type A, so I'm going to use drug X. There is no such a thing. So maladaptive plasticity is something that happens in all chronic pain patients, but it doesn't really help me when I'm with a patient to understand how to treat. It's important to understand mechanisms, but it doesn't give me a hint on what to use, because it's a general thing. It's like saying that cancer has mitosis problems. So yeah, all cancers may have some mitosis problems, but which problems, where, when? You don't have a treatment for mitosis problems. You have very specific treatments in cancer treatment. Pain is more or less the same thing. When you talk about maladaptive plasticity, you're talking about a general mechanism that is super important, but it's everywhere.
We have a few more questions. What really works for neuropathic pain in cancer patients? And do you have any tips to address the concerns of the patients and caregivers? Any specific tips?
What's the last part? Patients and caregivers.
Yeah, what do you have any practical tips to address the concerns of the patients and caregivers regarding pain management?
That's important, because sometimes patients don't understand that pain is something that can be treated. They just think, oh, it's because of my cancer. And they don't really know that sometimes you have patients with cancer that is cured and pain continues. So there is some education to explain that, of course, you're going to treat patient because pain is painful, but also because it's possible to have pain that continues despite a cancer that is cured. And that's not obvious. And that's more or less what happens with some of the pain types that I mentioned. About neuropathic pain, if you follow the guidelines for neuropathic pain in cancer patients, I guarantee neuropathic pain will not be the worst nightmare in your life. Most patients respond. If you follow guidelines, if you follow the guidelines for cancer treatment, cancer pain treatment, probably patients will continue to have pain, because the guidelines in general still treat everyone like having cancer pain, but people have specific types of pain. But if you try to apply the guidelines, for example, of neuropathic pain in general, in patients with cancer pain, it will not be the hardest patients in your life. The most challenging patients have cancer with nociplastic pain or cancer with nociceptive pain, not really neuropathic pain. That's my impression.
Yes, we have another question. Are gabapentinoids effective in neuropathic pain?
In average, yes, but these are not mega super good drugs. It's not like you need, the NNT is like 6, 7. So you need to try. If it works, it's fine, because these are relatively clean drugs. Of course, there's a lot of reports on abuse of gabapentin, but there's abuse in everything from sugar to fentanyl. So abuse is another issue. But if it works, it's fine, because it's a drug that is not metabolized. It's easy to titrate. It's not it's not nephrotoxic, even though you need to adjust the dose for kidney function. So it's worth a try, but the NNT is very high. The odds of having a patient that takes gabapentin and getting super well many times in a day, it's unlikely. You're going to have 1 or 2 out of 7, 10 getting better.
Okay. Do you see polymorphisms taking place on therapeutic options in the future?
In some countries where you have a lot of generic variants, for example, in Scandinavia, before using tricyclics, many centers do P450 4G6, for example, assessment. But I'm not very crazy about polymorphism, to be honest. Also because they're looking at what we should produce, but it doesn't tell us if we are actually producing these proteins. I think there are so many other variables in our metabolism that are more important than just the, yeah.
There is a question. I'm not sure I get that question in the first place. Can you please put more light on neural adaptation of chronic pain mechanism? Does this neural adaptation also on that level that this can still sleep, and any comments on transcranial stimulation of pain management?
So the first part, what you're calling neuroadaptation or maladaptation, is what I mentioned concerning maladaptive plasticity. It's the same thing. It's a process. It's a mechanism. Just like talking problems with mitosis in cancer. But it doesn't really help me. It helps me to understand what's going on, but not really to treat patients. Transcranial magnetic stimulation is a technique that is approved in the US for the treatment of depression since 2008. In the last 25 years, we have been studying a lot in the chronic pain world, mainly for neuropathic pain, fibromyalgia, and migraine. And it's got very good results, actually, for these indications. And as I mentioned, we call it TMS, but it's transcranial magnetic stimulation. TMS is getting to guidelines of neuropathic pain management. So there's enough evidence to suggest that patients with neuropathic pain can be central or peripheral. If you stimulate the motor cortex, there's a certain protocol you need to use in very low intensity. You can improve pain. Usually you do 15 minutes of stimulation from Monday to Friday, and then once a week, 15 minutes a week. And sometimes even 15 minutes every 2 weeks for a few months.
Okay, and the next question is, apart from TENS in physical therapy, which other modality can be used in chemotherapy-induced neuropathic pain?
I mentioned in this slide, if you come back to the slide, you're going to see there's a lot of modalities. You can use, if the neuropathic pain is focal and peripheral, like a nerve lesion, you can try TENS. TENS is not wonderful. And we don't have a lot of evidence that's amazing, but we don't. But you can try capsaicin, highly concentrated capsaicin, so 8% capsaicin, which is not the normal capsaicin. It's called Cutenza. It's a specific capsaicin that you need to know how to use it. You can use subcutaneous botulinum toxin. You can use lidocaine patches, and you can use systemic drugs. The best drugs with the best efficacy profile is tricyclics. Of course, if you are older, if you have contraindications, antidepressants like duloxetine and venlafaxine, gabapentin, pregabalin, and opioids, and TMS.
Yeah, can you mention few assessment tools?
There's 1,000. But for example, there's one, well, of course, visual analog scale and these things, but to look for pain intensity. But for example, we use the McGill Pain Questionnaire, which is, it's called McGill, like the university in Quebec, McGill, McGill, I can write here, which assesses dimensions of pain, affective, cognitive, and sensory dimensions. There's another tool called Brief Pain Inventory that was invented in the cancer world that we use a lot in non-cancer patients, the Brief Pain Questionnaire from Cleveland. There's a very important one called DN4, Douleur Neuropathique 4. It's a French name. DN4, it's a screening tool for neuropathic pain. If the patient has neuropathic pain, you can use a very nice tool that is very robust called Neuropathic Pain Symptom Inventory, which is a relatively simple questionnaire where you ask the patient from 0 to 10 how much it burns your pain, how much it's tingling from 0 to 10. So you have scores that are relatively easy to interpret. It's called NPSI, Neuropathic Pain Symptom Inventory. We assess fatigue, we assess sleep. Yeah.
That's all. We have covered almost all the questions. If you have any closing remarks.
No, I think it's fascinating to talk to you guys. I think every one of you will have your own experiences, and some things that we present, you may say, no, not in my patients. I've done exactly this. It doesn't work, because we're seeing different people with different culture. And what guidelines say, it concerns groups of patients. Individuals are individuals. They don't follow the guidelines. They're unique. So the exercise here is to take what is recommended and individualize to patients using their preferences and the scenario where you are seeing them, resources of the place. And this is an exercise that only you guys can do. I think it's fascinating to have so many people interested in pain. If I had to take one take-home message, there is a lot learned about. There's a lot of learned about management of pain outside the cancer world that might help cancer patients. Also, because thank God, you guys are doing a wonderful job, and a lot of patients get rid of cancer and they get cured, and they become people who have symptoms that may continue. So they become chronic pain patients sometimes, who are not even seen sometimes by the oncologist because they were discharged, but they still have symptoms.
Thanks again, Daniel. Thank you very much for the wonderful session. We have few announcements. We have a dedicated X handle and a mailbox. The links are posted in the chat box. You can copy them down. And we are in the process of establishing a LinkedIn community. As soon as we do it, we'll let you know through the newsletter. And those who want to join the EAPC Research Network Junior Forum, kindly send us an email or make use of the link in our EAPC webpage to send us an email. You can use both the mailboxes as our Outlook mailbox or the EAPC webpage mailbox. And the usual process is, as soon as we receive your email expressing interest in joining the Junior Forum, we'll send you a form wherein you have to give us some basic details, where you are working, what is your area of interest, and your field of specialization, like that. And you have to send it back to us. Then we will add you to the database and our mailing list, and you'll start receiving our newsletters. We are planning to conduct quarterly webinars and hoping to arrange our next webinar before the close of this year. So far, this is our second webinar for this year. We didn't have any webinar in the first quarter. And we are open to topics on which the members are interested for us to arrange webinars, or you can email us your suggestions. And also, if you have any particular speakers in mind, kindly let us know. We'll try our best within our limits. And that's all for now. With this, we are closing this webinar. Thank you very much, everyone, for making it a success. We hope to interact with you all in the next webinar, which hopefully will be before the close of this year. Thank you very much.